Hi, everybody. My name is Adam Pick, and if I have yet to meet you, I'm the patient who started HeartValveSurgery.com all the way back in 2006. Today, we have a very special webinar, which is SAVR, surgical aortic valve replacement, versus TAVR, transcatheter aortic valve replacement. What should patients know? And as I mentioned, our mission here is to educate and empower patients. And this webinar, which has had registrations from patients in over 550 in number, designed to support that mission. Now, during the webinar, you're going to be in what's known as listen-only mode, but I encourage you to submit your questions in the control panel that's on the right part of your screen. And I'll tell you why as we get to the agenda for today's webinar. I'm going to introduce the featured speakers. We're going to talk about aortic valve disease, have a meaningful conversation about SAVR and TAVR, answer your questions, and then as we wrap up the webinar, I'm going to ask you to complete a very quick 5-question survey to help us enhance these community events in the future. Now, for the introductions, I would submit to you that we have on the line with us today really a dynamic duo of aortic valve replacement. We have Dr. Charles Davidson on the line, who's the professor of medicine, a clinical chief, division of cardiology at Northwestern University Feinberg School of Medicine. He's also the medical director at the Bloom Cardiovascular Institute at Northwestern Memorial Hospital in Chicago. And one thing I know about Dr. Davidson is he's one of the leaders when it comes to clinical trial research. I know of his work on the partner trial, Evoke, Early TAVR, Pascal, Repair MR, and many more. He's a consultant and he receives grant support from Edwards Life Sciences and Abbott. So we've got a wonderful interventional cardiologist with us. We also, hey, Dr. Davidson, we also have the other really big member of the heart team, which is Dr. Malaisrie, who is a professor of surgery at the Division of Cardiac Surgery at Northwestern University Feinberg School of Medicine. He's the program director, thoracic surgery residency and fellowship at Bloom Cardiovascular Institute at Northwestern Memorial Hospital. And as you may have seen over the years in all of his videos at HeartValveSurgery.com, he specializes in minimally invasive and very complex valve surgery, including valve-sparing aortic root replacement and the Ross procedure. Like Dr. Davidson, Dr. Malaisrie is a clinical trial specialist. And right now, I think he's working on several trials, including Partner 3 Valve and Valve, the Medtronic Apollo trial, and the CryoLife PROACT 10A trial that has gotten a lot of attention at HeartValveSurgery.com recently. He is a consultant to and receives grant support from Edwards Life Sciences. Now, in addition to all of these incredible credentials for both Dr. Davidson and Dr. Malaisrie, what I know after seeing them in the operating rooms at Northwestern and seeing them in the cath lab and seeing them in the hybrid operating suite, I know what really drives these two men, and it's not the credentials. It really is the success and the health of their patients. And over the years that we have partnered with Northwestern Medicine, several hundred patients have found their way to Northwestern to have not just successful, but extraordinary results. And so here you can see whether it's Paul Powers, Jesse McBride, Gene Frank, Janice Kielbasa, Jim Whitney, the list goes on and on. And with that, I can do nothing but thank Dr. Davidson and Dr. Malaisrie for all their past work with patients and all the future work they're going to be doing to help folks just like you and me on the line. And with that said, I'm going to go ahead and turn this over to Dr. Charles Davidson and Dr. Chris Malaisrie.
Thank you, Adam. It's really a pleasure to be on again this year and to be able to speak about transcatheter aortic valve replacement, which has had really a transformation in the last couple of years. And when we were putting together this talk, Chris and I, it was amazing how much it's changed in just a short period of time. First of all, it's been an absolute honor, privilege, and a ton of fun working with Chris over the years. I think we've been at this for 15 years together. Chris remarked the other day, I think I know your next move before you make it. And I said, same thing with you. It's really this type of partnership that we've developed that has led to what we wake up for in the morning, which is getting great patient outcomes. And hopefully the clinical trials help move that forward. And that's what we're going to try to present with you today, is what's going on today with transcatheter aortic valve replacement. So why don't we get to the slides, and maybe you could click to the next one. So for those that want an anatomy of the human heart, how does it all occur? You look at how blood gets into the heart. It comes in from the superior vena cava and inferior vena cava, the big veins in the body, to the right atrium, goes through the tricuspid valve, and there's a lot of information, a lot of work Chris and I are doing on that, but that's not what we're here to speak about today, maybe for another day. Goes through the right ventricle, goes out to the lungs, gets its oxygen, comes back to the left atrium, then goes through the mitral valve, and then what we call the main pumping chamber of the heart, the left ventricle, and then out through the aortic valve. And today we're going to focus on that aortic valve because it can both block up what we call stenosis, or it can cause leaking, which we call aortic regurgitation. So it's kind of the final exit point of the heart and the blood to the rest of the body. Next slide, please. So as I gave you the information of how blood gets through the heart, aortic stenosis is generally calcified blockage of the valve. There are other causes of blocking up aortic valves, but far and away it's calcific aortic stenosis. This is not something that occurs because of bad diet or not a lack of exercise or even other factors that we might think about with coronary artery disease, high cholesterol. Those aren't clearly related to this. Sometimes, very frequently in younger patients, it's due to a valve that was not properly formed from the day they were born, called bicuspid aortic valve disease. And I know Chris will talk about that. He's clearly one of the world's experts really in that. And also tricuspid aortic valve stenosis, which means it has 3 leaflets that come together but have now developed calcium over time. And this can occur early in life, but generally occurs kind of as we get into the 60s and then above, 70s, 80s, 90s. Chris and I did someone a few years back was 101. She lived till she was 110 and did not die of her aortic valve. She was a really sharp person, actually was born the year the Cubs won their last World Series before the most recent one. Next slide, please. And so just an overview of it, aortic stenosis develops blockage in the aortic valve. Therefore, the pressure in the ventricle, the left ventricle, has to increase in order to get blood out there. That puts a strain on the left ventricle, and therefore you get a thickening of the heart muscle. And over time, that heart just can't generate that increased thickness. It gets very stiff or actually dilates, and that's when we start seeing heart failure. Now, we can see heart failure with aortic stenosis before it dilates. Clearly, we want to get to it before it dilates. The cardinal symptom that we see in the vast majority of our patients is shortness of breath. Some will present with chest discomfort, almost like angina, and others have lightheadedness or passing out spells. Those are very, very ominous signs when they develop passing out spells from aortic stenosis, and something that needs to be treated more quickly. But far and away, I'd say 80% of patients come in with increasing shortness of breath. We're going to talk about treatment options here. This on the right here, greater than 75, this is up for discussion. I think Chris and I could go on back and forth on this for a long time, but just some general ideas. Over 75 to 80, TAVR is generally preferred. 65 to 75, TAVR versus mini thoracotomy. We'll talk about both of those. And this is really where the shared decision-making between the patient and the heart team comes in. I see a typographical area, but it's really the heart team is so important here, and the patient, to really decide what's best for you and that patient. And we can make recommendations, but what we could say is this is 1, this is 2, but obviously you may have multiple options. Less than 65, mini thoracotomies, which is a surgical aortic valve replacement, is preferred, and less than 50, a mini thoracotomy with mechanical valves, or even a Ross procedure, which I think Chris will go through in a little bit. Aortic regurgitation, that's a leaking aortic valve, can develop suddenly or over decades. Once severe, that is a surgical treatment. There are not approved transcatheter treatments available at this point in time, and so if that occurs, that is a surgical treatment. And why, you ask, is the difference? It doesn't have the calcium within the valve. The calcium is what anchors that transcatheter valve. The valve's not closing tightly. Blood's pumped out of the ventricle, leaks back in, And sometimes with this disease, symptoms don't come on till late in the course of the disease. So if we detect a murmur and we follow it up with an echo, we need to continue to follow those patients, because with regurgitant lesions, often symptoms are late onset and often damage has been done to the heart. And again, no TAVR devices right now. Surgical valve replacement repair, mini thoracotomies, aortic valve replacement are the hallmark treatment, and with excellent results in good hands. With that, Chris, I'm going to toss it over to you for the next group of slides.
And Adam, thanks for having us back again this year. It's really exciting to be talking to your audience. And after 15 years of working with Dr. Davidson here at Northwestern, we've accumulated a tremendous amount of knowledge in aortic valve disease. And we've been very excited to see the progression in technology and all of the options that are available to our patients with both aortic stenosis and aortic regurgitation. And here this slide shows the tree with two approaches for patients with aortic stenosis. So those are valves that are calcified and too tight. And transcatheter aortic valve replacement, or TAVR for short, has also progressed over the past 10 years. Before, we talked about TAVR for old and elderly patients who are high risk for surgery, sometimes not even a candidate for open heart surgery. Now, TAVI or TAVR is an option for patients who are low risk. So we're looking at TAVR for younger patients. And this is really exciting because with the indication expansion, I think more patients will see this as an option for aortic stenosis. Aortic valve replacement seen on the right here has also progressed. We've had great experience with minimally invasive aortic valve replacement, and that goes to the next slide. So with patients with aortic stenosis who need open heart surgery, patients don't need to have a complete sternotomy. Patients can have minimally invasive cardiac surgery, either through a partial sternotomy seen on the top picture here, and preferably through a mini thoracotomy. So this gentleman all the way at the bottom here has a small incision. It's horizontal, off to the right. It does not involve splitting the breastbone. This is our favorite approach for AVR for patients who are not candidate for TAVR. Next slide. Now, the Ross procedure, pioneered by Donald Ross and iterated by Ross-Yacoub, is a procedure for patients who are less than 50 years old, who have aortic stenosis, who are considering other options that don't involve an artificial valve. So this is a procedure where the aortic valve is removed but replaced by the patient's own pulmonary valve. The pulmonary valve is moved over in the aortic position, and in its place, in the pulmonary place, we use a human pulmonary valve, where the human pulmonary valve, also called a homograft, lasts much longer in the pulmonary position because it only sees low pressures from the blue blood that goes to the right ventricle. So this is an exciting option for patients who are less than 50 years old. It offers them an opportunity to have a long-term durable result with likely better survival without the need for anticoagulation such as Coumadin. Next slide. TAVI has progressed over the past 15 years. You look all the way to 1992 when the first transcatheter valve was implanted in an animal. And then the first company was founded. It was called PVT. That was back in 1999. And the first TAVR performed by Elaine Cribier in 2002 in a human. Edwards acquired this company called PVT and started to work on in-human trials that eventually led to commercial approval. These were through a couple studies. Edwards led the PARTNER study. Medtronic led another study. And by 2007, TAVI was approved with 2 different valves for high-risk or inoperable patients. The next iteration of trials came through that looked at TAVI for intermediate or medium risk patients, and that was approved in 2011. And these approvals came through, as you see here, and finally in PARTNER 3, as well as the Medtronic Evolut trial. These are the low-risk patients, the last group of patients to be studied, and that approval came through in 2019. Dr. Davidson and I are very proud to be leaders in all three of these trials, Partner 1, 2, and 3, and we've been glad to offer this results to our patients, both in an investigational setting as well as in a commercial setting. Next slide. This shows the iteration of valves for both companies, Edwards on the top, Medtronic on the bottom. So what's the same about all these is they're all tissue valves. They are not mechanical valves. These are made out of tissue from an animal. The frame is metal, and that's what allows the valve to be anchored into the heart without coming out. And the differences as you move from left to right have to do with the mechanisms that are designed to reduce leaking from around the valve. So on the top one, you can see a skirt starting at Edwards Sapien 3 that has been molded to a little bit higher skirt in the Sapien 3 Ultra. Similarly, for the Medtronic Evolut, you could see covering on the bottom of the valve, which is also designed to reduce leakage around the valve, which has been iterated in the Medtronic Evolut Pro. Next slide. Our favorite approach for TAVI is through the groin. So that's through the femoral artery in the groin, through a percutaneous approach. So no open incisions. And that's what we mean when we say transfemoral, preferred. And that is the heart all the way on the left. 90 to 95% of patients can have their TAVR procedure through a transfemoral approach. So that's most of the patients. A minority, 5 to 10%, will need an alternative access. Our preferred alternative access, when the groin is not an option, is through the carotid artery. This is done with general anesthesia through a small incision on the neck, and we can access the carotid artery to deploy the TAVR valve. Next slide. Here's a video of a typical transfemoral TAVR through the groin with an Edwards Sapien 3 valve. So after access of the groin without an incision, this is done percutaneously. A balloon is passed over a wire into the aortic arch, past the aortic valve. The balloon is inflated to pre-dilate the aortic valve, which is calcified and tight. This valve is removed from the body and subsequently exchanged for the valve, which is mounted on a thin catheter. Here you can see the valve that is crimped down on the catheter in order to allow it to be passed through the femoral artery. The balloon can be mounted inside the valve, and now the valve is ready to be deployed. The valve is fine adjusted on the balloon and then passed around the aortic arch over the same wire into the aortic valve. You'll note that the old aortic valve is not removed in the TAVR procedure. It is left in place and provides a mechanism for anchoring of the new TAVR valve inside the heart. Once the catheter is in position, we can steer the valve to optimize the position. This is done under fluoroscopy. Here, the fine tuning is again illustrated here to get the valve in a perfect position. The heart is briefly paced and a balloon is inflated. The balloon is removed, the valve is left in place. That is fully functional. The catheters and sheaths can subsequently be removed from the groin and the small percutaneous access secured. And here's the final video of the functional valve in place. Next slide. So why do we choose TAVI versus AVR? So there's advantages for TAVR procedures. The biggest advantage is it is minimally invasive or non-invasive. So for patients who've had cardiac caths in the past, to look at coronary arteries by angiogram, it is very reminiscent of this procedure. Cardiopulmonary bypass, otherwise known as the heart-lung machine, used for open heart surgery, is not required for TAVR. Because of this, recovery time is reduced. Many patients are discharged the day following the procedure, and most are discharged within 2 days afterwards. There's also less risk of blood loss, so therefore less risk of blood transfusions, and post-operative atrial fibrillation has a risk rate in the single digits after TAVR. The risks with the TAVR procedure include not being able to take out the aortic valve as we do in open heart surgery. So the aortic valve is left in place, but it does provide an anchor point for the TAVR valve to seat in the heart. Major vessels are accessed, particularly the groin. So these arteries occasionally can be injured, but easily repaired. The risk of stroke has decreased significantly with TAVR procedures and are equivalent or even better than open heart surgery. Perivalvular regurgitation, which is leakiness around the aortic valve, has similarly gotten better with valves that have been developed over the past 10 years, so that we expect almost no one to have any significant leakage around a TAVR valve. Next slide.
Let me pick this up. I'll pick it up from here, Chris, and then turn it back to you.
I think so, yeah.
Yeah. So, let's go through some of the data that supports the statements that were made on the previous slide. This is data extracted from the PARTNER 3 trial, which, as Chris mentioned, is the low-risk trial. It's the most recent one that was done. And I think what's important when you look at TAVR is to look at the fact that we're now in our 4th generation of valves. So much of the things that plagued the early data with TAVR and why we just did high-risk patients is that we had leaking around the valve. There was large devices, so bleeding from the groin was reasonably high, and there was higher stroke and death rates. As we've now moved to the 4th generation and with a lot of operator experience, the data has really flipped, and that's what generated these low-risk trials. So to say is, can TAVR actually compete with surgery as a viable treatment option in low-risk patients? Not necessarily is it better or worse, but is it even a valid comparison? So these are what we call Kaplan-Meier curves. They're survival curves. They explain event rates. So if you look on that vertical axis, you see this slide looked at death, stroke, and rehospitalization. That was what we call the primary endpoint of the trial. So it randomized patients to either TAVR or open surgery. What we found in this, and if you look at where it says 12 months after the procedure, is that there was actually less death, stroke, and rehospitalization in the TAVR group compared to the surgical group. Now, recently, the 24-month data has become available, and it shows a continual improvement compared to surgery in the endpoints of death, stroke, and rehospitalization. So in the next slide, I'm going to drill in a little bit more. And so it was 17% versus 11%. Now we're into the next slide. Let's look at just death and stroke. At 12 months, there was 3% death and stroke in the surgical group, shown in that yellow line, and 1% in the TAVR group, which was a p-value of 0.02. Anything less than 0.05 is considered significant. So it was marginally better, with a change of about 2%. Now out to 2 years, it looks like the two curves have converged. So that we're seeing that basically at 2 years, the incidence of death or stroke are the same for surgery or TAVR, meaning that we have some equipoise here. It really gets back to that shared decision making. How old's the patient? What are some of the comorbidities? What's the patient and family preference? What's the anatomy look like? So there's many factors that can go into this decision. But if we have a patient population as was studied in partner 3, we know that we can provide equal death or stroke rates, less rehospitalization, but equal death or stroke at 2 years. Next slide, please. Looking at a little bit more of the endpoints, these are ones that came out at 1 year. Some of the things I do want to highlight is that we looked at bleeding. It was actually higher in the surgical group. Now, bleeding is really those that required transfusion. It may not have been it's counted as a major bleed anytime you get a transfusion, but in my mind, maybe that's maybe a bit of a misnomer, but albeit those are the definitions, and it was lower in the TAVR group at 30 days and also at 1 year. AKI means kidney injury. Was there a problem with the kidneys for some period of time afterwards? In the first 30 days and at 1 year, it was slightly in favor of TAVR, 0.05 being the p-value, so therefore we'd say it's insignificant, so borderline. As you can see, they're low frequency events. There are only 2 in the TAVR group and 8 in the surgery group. So once again, we're dealing with small percentages. A trial of this size is not going to really detect a difference, even if it did occur. Pacemaker rates were something that people talked about a lot with the early TAVR results. Higher pacemaker rates were thought to be occurring with that. Different techniques, different technologies, and with at least with the Edwards valve, the SAPIEN line of valves, the pacemaker rates in these 2 trials were identical. Now remember, these are not bicuspid valve patients. These are tricuspid aortic valve stenosis, and the results look like they were equivalent in those 2 populations, surgery compared to TAVR. Next slide, please. And then finally, on my slides, what I wanted to finish out with is functional outcomes. So we talk about stroke and death. Obviously, those are the 2 most important outcomes that we want to monitor. But other things we looked at is functional class, and this is a way of measuring how well did patients feel pre-procedure compared to post. And if we looked at people in the TAVR group, they actually seem to get better quicker, as you might expect, since it's not an open procedure, at 30 days. But by the time we got to 1 year, they were essentially identical. And we looked at the 6-minute walk distance. Again, better at 30 days in the TAVR group. But once you get out to the 1 year endpoint, it looks about the same p-value, 0.94. And this is a KCCQ, so it's a quality of life measurement based on a questionnaire that patients filled out. Once again, quicker recovery, better feeling at 30 days, but follow it out to 1 year, about the same. So quicker recovery. Some of the secondary endpoints looked a little bit better with TAVR, but when you look at the main endpoint of death and stroke at 1 year, a little better with TAVR, same at 2 years. And if we look at rehospitalization, that seemed to be fairly durable throughout the 1 and 2 year time frame. Chris, back to you.
Thanks, Charlie. I think a lot of the audience have previously heard us talk about the valve-in-valve procedure for failed tissue valves. This is also a TAVR procedure, but for a different reason. Previously, patients who had bioprosthetic valves or tissue valves were older patients. And when those valves failed, they either faced reoperative surgery or the valve-in-valve procedure. And we're very excited to bring this back online several years back for high risk and inoperable patients. But now we're glad to lead a low risk trial that have demonstrated very safe and effective outcomes with a valve-in-valve procedure in patients who are younger and lower risk. So this will soon become available for younger patients who get a tissue valve that later go on and have a failed tissue valve. So many patients will not need to see a reoperative surgery for failed tissue valves. They can either get an Edwards SAPIEN 3 valve or Medtronic valve that is shown here. And those results are pending and currently awaiting approval by FDA. Next slide. The Achilles heel of mechanical valve, on the other hand, is anticoagulation. And here's a picture of an onyx valve that we use for patients who require mechanical AVR. Remember, these valves are extremely durable. We expect these valves to last a lifetime unless they get infected. But patients with mechanical valves must be maintained on an anticoagulant And currently, the only anticoagulant that is approved is Coumadin, otherwise known as warfarin. So this is an exciting trial that Dr. Davidson and I are enrolling here at Northwestern for patients who have an aortic valve replacement with the Onyx valve. These patients, after 3 months after surgery, can potentially get Eliquis, otherwise known as apixaban, as an alternative to Coumadin. So this drug has been associated with lower bleeding risks and is very convenient in that you don't have to test levels for Eliquis. So we are looking for patients to enroll in this trial, and this could be a potential option for patients who get AVR with mechanical Onyx valve. Next slide. I think Dr. Davidson will finish out with our experience, tremendous experience here at Northwestern with aortic valve disease.
So we started this program in 2008 with a Partner 1 trial. What we've tried to do, we now have a 10-hospital Northwestern network of hospitals, and in 2016 we opened this up at our Central DuPage Hospital. We had trained those physicians here. They've now done over 300 actually with 0 mortality, so getting great results out there. We've also expanded out to McHenry Hospital and Palos Hospitals, where we also offer TAVR there as well. As you know, we participated in the pivotal trials, enrolled intermediate risk patients with the second generation. Now we're doing the low risk patients. We've done over 2,000 transcatheter valve procedures, not just in the TAVR arena, but also in the mitral and in the tricuspid, where we do both repair and replacement. Some of those approved technologies and some are investigational and even early investigational. And Chris and I did the first ever U.S. treatment of a tricuspid valve with a clasp repair a couple of years ago. We are continuing to treat inoperable and high-risk patients and have expanded distribution of these patients to more intermediate and low risk with commercially available TAVR. Next slide, please. So I think this is, to me, the most astounding slide that we'll show here today. Look at where we came in 2008. This is Northwestern data. TAVR at that point made up 5% of the aortic valve replacements that were done. And now in 2021, year to date, we are almost 90% of these are being done with TAVR. And we talked a little bit about bicuspid and other indications for it, but it's really astounding how this field has really flipped in the last 15 years from a surgical only to a TAVR. But that's not the most important point. The most important point is we're also treating patients that previously would have been inoperable or very high risk for surgery and may have been turned down in many institutions. And now we have an opportunity to extend those people's lives and improve their quality of life. And I think that's the real big story about this slide. Not that the field has changed, but also that we're addressing populations that may have had limited options in the past or no options. Next slide, please. This is just looking at it by operative risk. You look at the far left, you can see basically they were all high-risk patients, inoperable. And once again, as it's moved out, you can see that the low-risk population now makes up about 12% of our overall TAVRs, 20% last year. So somewhere in that range. Again, this is where many of these people are younger and they need to think about the lifetime management of their valve disease. And I think that's a whole separate discussion, but something worth discussing. If someone is, let's say, 60 years old, has severe aortic stenosis, if they get a biological valve, they're likely going to need a second valve somewhere in their lifetime. And so that's where counseling comes in. Do we want to do a surgical valve this time and then do the TAVR valve inside of that surgical valve, like Chris explained to when they develop stenosis or regurgitation of that biological valve? So some people say, I want the TAVR this time and I'll do the surgical next time. But this is where we need to discuss this. And that's why I think you'll see this low-risk population will fluctuate at a lower number because they tend to be younger and likely needing a second valve if it's not a mechanical valve the first time through. Next slide.
Well, Dr. Davidson.
That's it for the formal presentation. Turn it back to Adam.
Yeah, thanks so much. And Dr. Davidson and Dr. Malaisrie, on behalf of not just your patients, but patients all over the country, all over the world who get to benefit from the research that you are doing, we cannot thank you enough for your commitment and Northwestern's dedication to really advancing valvular therapy, whether it is a transcatheter approach or a surgical aortic valve approach. And Dr. Davidson, I love how you ended talking about the lifetime management of valve disease, because that's become an epicenter as our patients, as we all live longer, and a lot of our patients need reoperations. That's become front and center to a lot of the conversations I've been having with patients. So thanks for bringing that up. And now we're going to go ahead and shift gears. We've been getting lots of questions, and it's time to open this up to I guess we'll do a rapid fire question and answers here. And I'll just go ahead and read the questions, and Dr. Malaisrie, Dr. Davidson, you want to jump in? I'm sure we will all appreciate your responses. Let's start with a question from Wilson, and he asks, I have both aortic stenosis and aortic regurgitation. Does that impact whether I can have a TAVR or SAVR? What should I do?
Well, listen, when you have aortic stenosis and aortic regurgitation, we see that very commonly. We call that mixed aortic valve disease. And for patients with mixed aortic valve disease, they can be treated very similarly as patients with aortic stenosis. So if you have mixed aortic valve disease, Wilson, you can be a candidate for TAVR.
Great. I hope that helped you, Wilson. I did not know the answer to that, so thank you, Dr. Malaisrie. Let's go on over to Greg. And as we all know on the line, valve disease is not isolated. A lot of patients will have additional cardiac disorders, whether it's atrial fibrillation, coronary artery disease, or an aneurysm. This question comes in from Greg. He asks, at 68, I've been diagnosed with severe bicuspid aortic valve stenosis, and I'm asymptomatic. It also appears I'm needing a double bypass procedure. There's that concomitant procedure. My surgeon is recommending a full sternotomy with a bovine valve replacement. Is TAVR not an option in my situation? Does the surgical team need more, quote unquote, room to work given the bypass?
Chris, why don't you take that one?
Yeah, so this is an interesting scenario because the patient has both aortic stenosis and coronary artery disease. So the treatments for those are aortic valve replacement and coronary bypass grafting. So that's what the surgeon is recommending here. That is perfectly reasonable option. And yes, the surgeon needs some room in order to do the bypasses depending on where they are. So this case would be done with a full sternotomy, not through a mini thoracotomy approach. However, TAVR can be an option depending on your risk group. If at 68 you're at high risk or have comorbidities that make you inoperable, then TAVR is also an option along with percutaneous coronary intervention, otherwise known as coronary stenting. These are often done in two different settings. Usually the stenting is done first, followed by the TAVR procedure. So TAVR is an option, but I tend to agree with the surgeon that if you're an acceptable candidate for open heart surgery, I think bypass with an AVR is probably your best bet.
I want to echo those thoughts that if you're an otherwise reasonably healthy 68-year-old with concomitant coronary disease and bicuspid aortic valve, really the first recommendation would be aortic valve replacement by surgery with a coronary artery bypass. And that's coming from an interventional cardiologist that does a lot of these. And if there was extenuating circumstances, let's say they had advanced hepatic disease, renal failure, other things that were not morbid obesity, there may be things that we're not seeing in this slide that could alter this conversation. But the vast majority of people, given what we have in front of us here, would be better served for an open approach.
Thank you so much. And now maybe Dr. Davidson and Malaisrie, I might throw you a curveball in terms of Greg's question. I imagine given the association of aortic valve disease and aneurysms, patients might be on the line having this exact same question. Look, I've got aortic stenosis. I've been told I have an aneurysm. Can that be done using TAVR or some hybrid approach?
Yeah, I mean, this is right up his alley. This is what Chris does more, probably better than almost anybody. But this is clearly a surgical approach. There's not a catheter-based approach to treat aortopathies and bicuspid aortic valve. And I'll let Chris elaborate on the techniques he uses for that.
Yeah, a lot of patients with aortic stenosis that are caused by bicuspid aortic valve, those patients often have an associated aneurysm. We estimate about half of those patients would also have an enlarged aneurysm. Currently, there are no TAVR options. TAVR is not to be confused with TAVR. TAVR is a stent graft that is designed to treat the aorta, but aorta in the descending aorta. So that's the aorta that runs along the spine. It's a fantastic option for patients with aneurysms in this area. However, TAVR is currently not approved for patients with aneurysms in the ascending aorta. That is the aorta that is next to the aortic valve. These have been done experimentally, including by us, for patients who are extreme risk with perfect anatomy. But for the run-of-the-mill patient with bicuspid aortic valve disease with an aortic aneurysm, right now surgery is the best option for you.
Great, thanks so much, Dr. Malaisrie and Dr. Davidson. And at HeartValveSurgery.com, we have patients as young as 5 years old, and as I've talked to patients as old as 95 years old. And this question is for, I'd say, more of the younger folks, and in particular the women on the call. Julie asks, are there any updates about TAVR approval for young patients? I'm wondering how, if TAVR might impact female patients with aortic stenosis who want to get pregnant.
So, Julie, unfortunately, there's not a ton of data on the very young patients. The majority of the patients that were enrolled in the partner trial were 65 and older, and much of that is actually predicated by the fact that CMS will reimburse for patients that are in clinical trials that are approved by the FDA, and therefore less than 65 requires kind of pre-authorization from the commercial payers. So we don't have a lot of data on TAVR in the very young patients. And the fact, though, that once an aortic valve replacement is done, whether it be surgical or transcatheter, these patients can go on to have pregnancies and fairly treating them fairly normally as we would. With biological valves, the anticoagulation for this is really aspirin alone and not any of the anticoagulants that we talk about like warfarin or the like. And I think the real question here is mechanical versus biological valves in a very young patient. And I think that's, again, a subject for a whole nother discussion, but those mechanical valves often require anticoagulation like warfarin that can impact the risk during pregnancy. So those need to be managed very carefully and should really be done in a heart center that has a dedicated group looking at women, young women, pregnant women, and how to manage them throughout their pregnancy with congenital heart disease. Chris, do you want to add some more to that?
Yeah, I think this question gets to the heart of valve choice for patients. And for patients who are considering pregnancy, these are obviously patients who are less than 50 years old. So which valve would you take? The Heart Association and the American College of Cardiology would recommend mechanical valves for most patients less than 50 years old, but not for patients who are considering pregnancy. Pregnancy would disfavor mechanical valves, and bioprosthetics valves are probably the preferred valve for young patients who are considering getting pregnant. So this also gets at the heart of lifelong planning of aortic valve disease. Because if you consider that bioprosthetic valves last maybe about 15 to 20 years at best, if a patient is in their 30s and takes a tissue valve, you may be looking at 3 procedures in your entire lifetime. So planning becomes very important. I suggest that with this complex patient, that you talk with your heart team and understand your options clearly and make a decision in conjunction with your physician.
Yeah, and Dr. Malaisrie and Dr. Davidson, Chris's question is a wonderful follow-on to the conversation that we're having about the lifelong management of valve disease. Chris asks, at 47, I already had SAVR. At 55, I had another SAVR, given limited data and higher stroke rates of TAVR at that time. I'm going to need another valve in the future. What do the doctors think I should do for the third aortic valve replacement?
Well, this is an excellent question, and probably we won't do a complete service here in this discussion. Getting back to the heart team. So at 55, unfortunately, 47 to 55 is not what we normally expect for a SAVR. As Chris said, 15 years is the number I usually quote and put some numbers around that, but 8 years is a little bit on the early side. This is someone, let's hoping that they're going to get to age 70 without needing another procedure, and if they did, that would be, to me, probably a person we'd think about a valve and valve on. And again, it depends also on what the size of the valve is that's in there. If it's a smaller valve, we might do another operation and then talk about a valve and valve. If it's a larger valve and we can start stacking TAVR valves, we might think about double valve and valves. Having said that, there's not a lot of data, very little, on more than one valve and valve procedure. So this is a great question, and I hesitate to give too much advice on this because a lot of it will depend on how long this second valve lasts and the size of the valve and then the risk category you're in at that point in time. How well did you recover from your first two surgeries is another important point that we need to keep in mind. So I'm giving you a 30,000-foot opinion here. Clearly not enough that if I was you, Chris, that I would be able to make a decision what to do, but you start framing a discussion that you're going to likely have to have. Chris, you want to add to that as well?
I think all those points are very important. For this patient, I think I would go into the mindset of valve and valve procedure first, unless the anatomy is not suitable for it. And this is really important because patients should go to centers that have advanced imaging that can study the anatomy of the aortic valve and the aortic root. Because some patients, valve and valve, are not suitable based solely on anatomy, and the surgery becomes the only option. But for this patient, it's a lot easier than the pregnant patient. I think this would be a valve and valve.
Yeah, thanks so much for that question. Again, here I threw you a curveball earlier. I'm going to throw you one right down the middle because I imagine you get this question all the time about TAVR and its lifespan. Shannon asked, does the TAVR valve last for less time than a valve implanted via surgery? What are the lifespans of the TAVR valve used today?
So this is not a straight fastball because we don't know the answer to this one yet. Because as we said, we started doing these 15 years ago in pretty much inoperable high-risk patients. So the best data we have at this point are only out between 5 and 10 years, which look reasonably equivalent, but we don't really have 15-year comparative data right now that we can cite to know whether these are different. It's the same valve material, whether it be bovine or porcine, made by the same companies that make the surgical valves. They are now, though they are implanted now on a metal frame, not on a surgical ring. And so they are done slightly differently. The old valve's not removed. So we don't know the answers yet, and we're in a fourth generation. So even if we looked back and tried to pull out some of the early data, it's a different valve design at that point in time. So more to come here. And what I tell patients is just what I started to hear today. The best data we have is they look equivalent, but we do not have 15-year data at this point in time to make a valid comparison.
Great, and we're getting close to only having time for one more question. So I wanted to ask a question that came up from Tina, and I think it's a really important question about the future, right? Where you guys are doing a lot of research, a lot of work with your team there. She asks, what is the future of SAVR and TAVR? How might these approaches to aortic valve disease change?
Go ahead, Chris. Why don't you start with this?
I think both approaches have changed so much over the past several years that I think I'm very hopeful that both procedures will get safer in the future. So for SAVR, minimally invasive approaches, I think will become more available across the country. Probably currently only a handful of surgeons will offer minimally invasive cardiac surgery for SAVR. In the future, I think that most surgeons will offer minimally invasive cardiac surgery. TAVR, I think the valves will also continue to get better. I think there's a couple challenges to overcome, but not that many. Perivalvular leak or leakage around the valve, I think, has been overcome. Pacemaker risk has similarly come down. But we're also looking to have TAVR approved for patients not just with aortic stenosis, but also with aortic regurgitation. So I think the indications will expand for TAVR. We'll get longer-term data to prove to the previous patient who asked the question of durability. Well, how long does TAVI last? We'll have that 10 years data probably in the next 5 to 10 years.
Yeah, and I would agree with everything Chris said. I think that the only points I'd want to highlight additional is we don't have really good comparative data on bicuspid aortic valve disease without aortopathy surgery versus TAVR. And I think that's something that we will need moving forward so that we can advise those patients better. And aortic regurgitation, although less frequently seen without an aortopathy, is an area that seems fruitful for also expanded technologies. I think I look at this like I did coronary stents and bioabsorbable stents and drug-eluting stents. We've reached a point now where we're getting to the very tip of refinement. We're making changes that were huge in the beginning, and now they're becoming less. So I don't see a large change in this technology right now because most of the limitations have been addressed. But I do think we need data on durability, bicuspid, and some technologies to treat aortic regurgitation.
Great. Well, thanks so much. And with that, I need to go ahead and thank everybody on the call today. Hi, everybody. It's Adam. I hope you enjoyed that video. And don't forget, you can always subscribe to our YouTube channel, watch the next 2 educational videos coming up on your screen, or click the blue button to visit HeartValveSurgery.com.